The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the HYPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. Easy flow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are 3 categorically different methods of blood processing: passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are 3 things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive 2-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive 2-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
Hello and welcome to PerfWeb 27, Day 2.
Day 2.
Welcome back, Tammy and Katie.
Thank you.
As you all may have met Tammy and Katie yesterday, let me just very quickly introduce them. To my right, of course, Tammy Sparacino, 2003 graduate from Texas Heart Institute. And oh wait, am I supposed to do the social media stuff first?
You are.
Whatever you feel. Oh, okay, good. Graduate of Texas Heart Institute and now working with us here at Houston Extracorporeal Technologies. Is that right? And also on our resident faculty for the PerfWeb, NurseWeb, web series, MediWeb series. That's right. And you were formerly at Memorial City. You worked at the VA, Ben Top, did a lot of really neat stuff, trauma, pretty much everything, ECMO, all that kind of stuff. And so welcome back. And immediately to her right, or second to my right, Katie Kim. You met her yesterday. She received her BSN at the Medical University, of South Carolina. And then her master's in nursing at Grand Canyon University. And she worked as an ICU nurse at St. Luke's.
And at Memorial.
And at Memorial. And then also you have worked as a education specialist at CHI St. Luke's, or what was St. Luke's, then became CHI St. Luke's, and now is the medical director, or the medical director.
He's elevating me
Big promotion today. Is the director of education for Guardia ECMO training, and also for our MediWeb programs. So welcome back again to you.
Thank you.
You're actually giving the first talk for today, and I'll just very quickly say what the talk is, and then we'll do the social media stuff. But you're going to be talking about advanced hemodynamic monitoring, and you're going to be talking, Tammy, about non-invasive monitoring devices, which can do a whole bunch of things. It's a really interesting topic because I think that it's something that we have a lot of monitoring, but do they really work, and are they really effective? And I think that both of these talks are going to be very important for everyone. Okay, the social media stuff. Please like us and share us on the Facebook. Please follow us and share us on the Twitter. And please make sure that you subscribe to our YouTube channel, as you see all of the stuff right here. So make sure that you do that. And then also, and there's the button for subscribing and all that, ask for notifications. And then our new LinkedIn account, and all of these can be found under, what do they get found under? MediWeb or David? How do they find it?
They're gonna be lower third.
On the lower, okay, so the sites will be on the lower thirds. You'll see it at the bottom of the screen, how to find these things on Facebook and all these other social media platforms. Also, our call-in number is 347-694-4400. The phone is right here. If you'd like to call in and ask a question, I hope somebody does. You can be live on the air and join in the conversation. So without further ado, we're going to go right into our talk with Tammy Sparacino, perfusionist. No, I'm sorry. We're going to go over to advanced hemodynamic monitoring by our medical director and director of education, Katie Kim, RN. So, Katie, the show is yours.
All right, awesome. So today we are talking about advanced hemodynamic monitoring. So I'm trying to take a rather complex subject and simplify it as much as possible. So there are 4 factors really that affect hemodynamic conditions. One is intravascular volume. The other is myocardial contraction, heart rate, and vasoactivity. So we'll start with cardiac output, which is your heart rate times your stroke volume. And normally this is 60 to 130 milliliters per beat. And it's a marker of delivery of oxygen to your tissues. So we really care about flow to the tissues, because if tissues don't get oxygen, what do? They die. They die. And so our cardiac output is used to guide our treatment. And it is really important to understand the difference between preload and afterload. Preload is the end diastolic volume, which is at the beginning of systole. So we're measuring a volume with our preload, how much is in the tank. And afterload is the ventricular pressure at the end of systole. So it's the squeeze on the hoses. And how do we measure this? The gold standard in most places, most centers, is going to be with a pulmonary artery catheter. And so the way that this is put into the heart is it is floated through your right atrium, through the right ventricle, and then sits in the opening of the pulmonary artery. And so as you go through right atrium, right ventricle, the pulmonary artery, you'll notice that there are pressure changes along the way and differences in waveforms along the way. And then finally, because there's a balloon on the end of this catheter, it kind of floats through so that it'll eventually occlude the pulmonary artery all the way, and then you'll get your pulmonary artery wedge pressure.
Do you know where Dr. Swan was when he came up with the idea of the pulmonary artery catheter?
I do not know.
He was sailing.
Well, that is, yes, because then you'd have the sails that move the boat.
Exactly.
And
that's how he came up with this idea of getting into the RV and then inflating the balloon or I guess they do it in the right atrium, but basically having it sail into the pulmonary artery.
Yes.
And that was Dr. Swan. He did that in California. It was like in the 60s.
Nice.
Yeah.
Nice. I didn't know that. Fun fact.
Fun fact.
Fun fact of the day. So the way that we determine the cardiac output is done in the past by thermodilution, but today's catheters now use a thermal filament within the catheter to measure the thermal energy, and so it's a continuous cardiac output measurement that you'll see. So what are the indications for a pulmonary artery catheter? There's shock of all types, assessment of the cardiovascular function and response to the treatment. So you're giving medications, are they working? You're giving fluid, are they working? Assessment of pulmonary status, assessment of your fluid requirement, and then perioperative monitoring. So you'll see this a lot, especially in cardiovascular surgeries where pressure differences are really, really important on both sides of the heart. What are the disadvantages? We all know that any invasive line is at risk for infection, and as soon as you introduce something that is foreign to the body, it'll start forming a fibrin sheath or like a biofilm on it, and that puts you at risk for not only infection but also increased risk of thrombosis. Just the sheer nature of floating the catheter through the right atrium, right ventricle can cause some irritation in the myocardium and put you at risk for arrhythmias. And then keeping that pulmonary artery wedge pressure measuring for too long, greater than like 15 seconds, it puts you at risk for pulmonary artery infarct. And even worse, if you overinflate that balloon over the 1.5 milliliter range, it can put you at risk for rupturing the pulmonary artery. So those are really bad things to happen. But the most common thing that happens in the nursing world, at least, is malpositioning. So it'll either be advanced too far, or more often something will get pulled, or the catheter won't be locked into place, and so it'll get pulled out a little bit, and then you have to come call someone in and get it repositioned, which is always kind of a pain. And so not very fun to deal with. But the advantage is that it allows for maximum monitoring. You can get so many measurements from the catheter, and there's multiple access points. So if you're infusing a lot of fluids, if you're giving vasopressors or inotropes or anything, you have a lot of access points to be able to do that from. So that's really great. But keep in mind that our patients who usually need a PA catheter also are pretty sick, and so they'll usually have some other kind of invasive line, like a central line or something that'll give even more access points, or maybe they'll just have peripheral lines and multiple of them, but regardless, they'll need something else as well. Clinical applications. For the basic parameters that the PA catheter is going to measure directly are the CVP, the PA pressure, so your pulmonary artery pressure, your pulmonary artery occlusive pressure, which is the wedge pressure, and your cardiac output. But then those numbers, using some sophisticated calculations, will give you the derived parameter. So your cardiac index is actually taking your cardiac output and applying body surface area to accurately make sure that we're accounting for your size. So, for example, someone who's 4'2" and weighs 110 pounds is not going to have the same cardiac needs or cardiovascular needs as someone who is, 6'4" and 300 pounds. So accounting for body surface area matters. You can also do this, index the stroke volume. So you can measure the stroke volume off of the PA catheter, but then index it, index your systemic vascular resistance, things like that. So again, all of these numbers or parameters to the right are things that are derived from the PA catheter, not direct measurements. Normal values are really important to understand because you have to know what normal is to understand what abnormal looks like. So for your right atrial pressures, those are normally going to be around 2 to 8 millimeters of mercury, whereas your ventricular pressures are going to be a little bit higher than that, but it's not going to be as high as your blood pressure is going to be, because that's actually looking at arterial pressures, and the right side of the heart is a low pressure, is the low pressure side of the heart. Your cardiac output is normally 4 to 8 liters per minute, and indexed for your body size, normal is going to be 2.5 to 4.3 liters per minute per meter squared. For PA pressures, normal systolic is 20 to 30 millimeters of mercury, whereas this is a PA diastolic pressure, 8 to 12, and your wedge pressure is going to be around 8 to 12 as well. So let's try and keep this simple. Think about the cardiovascular system as pump, tank, pipes, and flow. And so the way that we measure how effective the pump is by measuring the ejection fraction. So you'll get an echocardiogram to do that. And that's going to tell us, is it contracting the way that it's supposed to? Do we have enough force for us to pump the blood out of the tank? The tank is going to be what's filling up the heart. So you're going to measure this by your pulmonary artery occlusive pressure, so your wedge pressure, which is going to tell you the preload of the left side, and your CVP, which tells you the preload of the right side of the heart. And then we all know that you have your preload that has to then be pumped out and overcome the force on the back side of the heart, which is the afterload. And your systemic vascular resistance is going to be the measurement that you're going to have to overcome to get the fluid out of the tank, so to speak. And then flow is measured by your cardiac output and your stroke volume. So this is kind of on a macro level, a big level, high level overview. So what do we do about patients with hypotension? If they're hypovolemic, some of the things you're going to see are a low CVP, a low wedge pressure, low cardiac index, but then a high systemic vascular resistance index, because the body's going to try and compensate, and so it's going to try and speed up the flow out of the tank that is actually not full. So you'll consider a fluid challenge for these patients. For those who are cardiogenic, you'll have a high CVP and or wedge pressure, a low cardiac index, and you'll also see the high systemic vascular resistance because your pump isn't working effectively. So you're going to consider inotropes. You might consider something that will decompress the heart so that there's not so much fluid in the tank, because the fluid's going to overflow backwards into the lungs. So you'll consider those kinds of options. For your person who has vasogenic issues, like maybe they're septic and so they've got very leaky capillary beds and everything is hanging out in the third space, you'll see low CVP, high cardiac index, because we have a very, very low systemic vascular resistance. So all of your fluid that would be in the tank is kind of sitting out in the periphery. And so for these patients, you consider a vasopressor. So what about your mixed venous oxygen saturation? Why do we care about that? Because not only are you caring about macro circulation, you also want to consider microcirculation and actually getting to the tissue level. And your mixed venous oxygen saturation is directly measured from your pulmonary artery blood, and it's a marker of the balance between oxygen delivery and consumption. So whenever you have a decreased SpO2, you're going to think anything that's increased consumption. So maybe we have a fever, we're in pain, we are hypoxic, or we're anemic, we don't have enough hemoglobin to carry the oxygen, we're really agitated, something like that is going to decrease your SpO2. And the opposite is true if you have an increased SpO2, which means that you have decreased consumption. So this is basic economics, supply and demand, basically. So with your increased SpO2, generally that's we've sedated the patient, we've paralyzed them, maybe they have cyanide toxicity, so they can't actually offload their oxygen to the tissues, or we've given them the appropriate respiratory support that the patient needs to bring up what was a low SpO2, and now it's normalized. I love this little cartoon that basically describes microcirculation in a very easy to understand way. So basically your lungs are tanking up your hemoglobin molecules with oxygen, and so your arterial oxygen content is at 100%, and then your heart has to pump that out and deliver it to the tissues. But your tissues have a demand for the oxygen, and so they're going to consume about 25% of whatever oxygen is on the hemoglobin molecules, and sends it back up again to cycle back through the heart. And so your normal SpO2 is 75%. This is a fun little picture to talk about supply versus demand. How do you measure the flow? You can do that through the PA catheter, like I said, or there's also minimally invasive measures that I'll talk about a little bit, touch on. And then the non-invasive measures, which I'm going to leave for Tammy to discuss, to determine how are you going to measure your cardiac output. One of the minimally invasive measures you can use is pulse pressure or contour analysis. And basically, it's looking at or hypothesizing that your stroke volume is proportional to your arterial pulse pressure, and it will measure stroke volume and SVR with each beat, which is kind of cool. The great thing about this that has been used in practice when I was at the bedside is that it measures the stroke volume variation and can predict whether you need fluids versus pressors. And so if our stroke volume variation was less than 20%, we would give pressors because we would assume that the tank was full. If it was over 20%, then we would assume that the patient was dry, and we would try a fluid challenge for those patients. But the caveat is patients have to be vented, they have to have a regular rhythm, and that's kind of how you would know that it was accurate. Some examples of the minimally invasive procedure or measures to measure cardiac output: you have the auto-calibrated systems like FlowTrack Vigileo, PulseoFlex, LIDCO, externally calibrated systems, and then systems that are completely uncalibrated and they're connected to your standard indwelling art line, like your FlowTrack sensor. Tammy will go into some of these a little bit more in depth. And so everybody has been with a patient and they've seen waveforms like this. So what do you think that does if you're trying to measure your cardiac output off of an arterial line?
I think for pulse contour analysis, it's a problem.
It is a problem. It's going to make it inaccurate, right? So that is one of the major disadvantages of the pulse pressure analysis measure or way of measuring cardiac output, because it's relying heavily on an accurate arterial waveform, right? Under or over dampened waveforms are bad. And it's also reflective of forward flow only. So if you have any kind of artifact like that from a balloon pump, or if you have aortic regurgitation, it's going to make this very inaccurate as well. So for those patients, you would want to try something different to measure cardiac output. So here is just kind of a little practice scenario. just very basic. So you've got this 68-year-old male who's admitted to the ICU. He had a non-STEMI. He's medical management only. He had gone to the cath lab and comes back. They can't do anything about it, but he had some hypotension in the cath lab, so they left a PA catheter in. He didn't need to be intubated. He's only on 40% face mask, and he's currently has the hemodynamics listed below. So 9:30, his blood pressure is 82/48 with your map of 59. Your pulse is 126. His cardiac output was 3.1, index of 1.9. Stroke volume was only 25. His PA pressure's 22/11 with a wedge pressure of 7. CVP is 2, and his systemic vascular resistance was 1470 dynes. So the doc decides, well, let's give him 250 cc's, and we're going to do that quickly and see what's going on if this helps him. And at 10 a.m., his readings were that on the right, with his blood pressure slightly improved, MAP improved to 63, pulse was 130, his cardiac output and cardiac index went from 3.1 to 3.2, and then 2 liters respectively. Stroke volume was 25 still, PA pressure 26/16 with a wedge pressure of 10 and a CVP of 5 and an SVR of 1450. Now, would you say for this patient that was adequate for him?
I would say the treatment was inadequate, but the response was positive.
Was positive,
But
right?
I would say that 250 was
He needs more volume.
Exactly. So that's
significantly, yeah.
exactly what the doc decides
and I wouldn't-
next. So we're going to give another 750 cc's over an hour, and based off of the response at the 11 o'clock readings, was it effective? And why or why not?
Well, I mean, yes. I mean, it's
Yeah.
clear it was, but I do see a potential problem brewing. But, you know, I mean, I think the CVP's kind of high off of just another 750 to jump from 5 to 14. But there's been a positive response of blood pressure, pulse rate's reduced, output is increased, and the PAD actually doesn't look that. I mean, the PAD looks fine. It's actually gone down a little bit. But the CVP jump from 5 to 14 seems a lot.
Right.
So I'd be a little concerned about the guy's RV.
Correct. And so that's kind of how we use the...
That was
You
correct?
did.
I did good?
You did good. You did good. Yes. So yes.
I was stressed. I was under pressure. I can't get this wrong.
So that's exactly how you use your knowledge of what's normal and what's abnormal to guide treatment, and you see what does the trend look like. We're not always going to take one set of numbers and say we've done it, we fixed him. We're going to look at the total picture, and we're going to use what we know to be normal to treat what's abnormal in
That
the
makes
situation.
sense. Makes a lot of sense.
So with that, I might have gone a little fast.
A little, but that's okay. So, hey guys, do you want to? How about if we go ahead? Since I know yesterday you had said, because we're going to still have a discussion afterwards. Well, let me ask you a couple of questions,
Sure.
and then we can maybe do a short break, and then we can go from there. So, placement, you know, with showing us those waveforms, arterial waveforms. We've all seen it many times. And in the operating room, it's very frustrating because, of course, the patient's arms are down by their side, they're tucked, and when they put in those little short radial arterial lines, you know, about this long, any pressure on it, or if they just don't have it really placed well, or they have any kind of peripheral vascular disease of any sort, or just a really
Or they
small
lean on
vessel,
it.
and they lean on it, we lose our pressure. And of course, when we're on pump, we have a continuous flow. Our pumps are historically continuous flow, so we don't have even a waveform to look at. All we know is our mean is 30, but is it really 30? And then we try to come off pump, and the waveform looks terrible. With the pressure is really low. Everybody's talking about wanting to get out the rocket fuel, and the next thing you know, it's like, whoa, wait a minute here. my pressure back here is a whole lot higher in terms of the mean than what you have up there. And they'll put another line and the femoral will look great. Line placement's so important. Why do we have such short, poorly placed radial arterial lines historically in the ICU, and not something you can put it in radially, but have it be a much longer catheter that's up closer to the brachiocephalic?
I don't know the exact answer to that question, but I would assume that it's such a mobile placement, and you could end up with arterial damage and things of that nature because the patient's
But it's in
constantly
there.
doing
It's
this.
in there anyway.
But if it's only about an inch,
Oh,
it's not as likely to
of
cause.
course, put an arm board on it
Yeah.
and do that, or put it in higher. What about putting it in higher? Maybe it'd be harder to
think it
do,
would be
but with
harder to
ultrasound,
do.
it shouldn't be as hard. Anyway, well, I just think that it's an interesting problem because, I mean, your experience as an ICU nurse, is this a problem that anyone else who's watching out here that spends time in the ICU sees and feels the same
Yes.
anxiety?
Yes, your patient has to be pretty immobile for a radial art line to work. But the same thing happens with the femoral lines. They start curling up their legs, and all of a sudden you don't have a good waveform. And so
Right.
a lot of times in the ICU, you're doing non-invasive checks
Like
just to see
cuff
if they
pressures
to
every
see if
hour
they
or something.
correlate with your arterial line, because it's really important that that you know what that blood pressure is, because it's
Yeah.
going to affect everything that you do.
It's like a big deal.
It is a really big deal. It
And
is.
yet it's so poorly done. And for how many years, decades, that we've had chronic, poor arterial pressure, continuous arterial pressure readouts. I mean, it's kind of like just a common problem that we've had in the 40 years I've been doing this, I've seen
Yeah.
it.
Yeah.
From 40 years ago. And we still haven't figured it out and fixed it because it is a chronic problem.
Well, and if you're treating, specifically when we're on pump, if you're treating that with a pressor, and you don't need to be treating that
Yes.
with a pressor, you're doing a lot of damage.
You are.
Actually, I saw a patient one time actually have a very bad outcome secondary to that very problem. They were the arterial line pressure was not reading properly, but no one recognized that was the actual issue, and they were pouring neo, levo, vaso in at massive doses to get a blood pressure, and that patient had a very big stroke and didn't survive the procedure because of that.
Well, I think you can also have the opposite effect too. I had a case recently where the pressure was reading low on pump, and I had already given, a stick or two, and I was like, okay, we're not getting a response, something's going on. But my anesthesia was not concerned. Oh, it's fine. It's better than that. But really doing nothing to investigate if it's better than that. So then you worry about hypoperfusion.
Of course. Yeah, right. I mean,
Right.
if you have a very, very low SVR, it doesn't do well for distal perfusion. It's
Right.
not good.
Right.
Either way is not good.
The point
And
is it needs to be addressed
Yeah.
as best you can during that time period.
Yes, I completely agree. I think what for me anyway, I think the real question, and I think the topic that maybe we need to really explore, is how do we continue to operate with a lack of confidence in the numbers that we're looking at? That
Right.
if we're supposed to be, we're monitoring the patient, and if we have a lack of confidence in something, that should, chronically, that should be addressed, because no one has ever, like I said, no one's ever addressed it. So on your filling pressures, patients on ECMO, PA catheter is out the window,
Yep.
not helping you any.
Not helping at all.
CVP, not going to help you too much.
Nope.
Or won't it? Will it? If you're on VV ECMO, will that affect your CVP? I mean, you may have flow jetting against the catheter line, but if you don't have that happening and you have it positioned in a place where even though the blood is moving around in there, the blood's normally moving around in there, right? The pressure should be the pressure because it has to do with the chamber size and the relative tension that's being applied to it. So does VV ECMO really affect our CVP?
I think it would depend on your catheter placement.
And I also think it depends on your flow.
Yeah.
Well, why? If the normal cardiac output is, if that patient's cardiac output is 6 liters, then there's 6 liters a minute that's going through that right atrium. So if we're just taking it out and running it through an oxygenator and running it back in at 5 liters, and their native cardiac output 6 liters, we're not even getting all of it, probably closer to 4 liters. So does it affect it? And I don't know the answer to that, but I'm trying to think, and I'm kind of thinking that it doesn't, and I want to know now because I don't really know. So now I want to know. Now VA ECMO, I think that the number is going to be the number. I think it's an accurate number because, again, I think it's measuring the relative tension of the chamber, but it's not reflective of what the actual CVP would be if we weren't on ECMO. Correct. So we're
it's a different
emptying,
number.
right?
Yeah.
We're empty, right? It is a different number because we're on pump. The atrium is completely collapsed. The CVP is 0. We see the CVP up there of 0 or 1.
All the time.
Yeah.
We're happy,
Yeah.
but
Yeah.
we're happy because we know the heart's empty.
Right.
Right, which is what we're trying to do with, on the right side anyway, in the with ECMO. But it's interesting because you can't really use the non-invasives. You'll talk about that on ECMO. I don't think. Well, maybe VV you can.
I don't know. I had a lot of trouble finding actual. A lot of articles said caution when you've got other circulatory, devices. But I had trouble finding a lot of studies that were like actual studies that were done for that purpose. So.
Don't preempt your talk too soon, because you're next. You're next on the chopping block. Okay, we still need to continue this conversation, but those quick questions. Do you want to go to a short commercial break and so we can keep the lights on and run a couple of our sponsor ads, and then we'll come back and load up Tammy's talk?
Okay.
Sound good?
Yeah.
All right, we'll see y'all back in how many minutes?
10 minutes.
About 9 minutes. 9 minutes. I don't like 9 minutes. It's either 8 or 10.
It's
I
10.
can't do an odd number.
10.
10 minutes. 10-minute break.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch. as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the HYPOTENSION device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are 3 categorically different methods of blood processing. Passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are 3 things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive 2-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive 2-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
And welcome back, everybody. And so we're going to go ahead and jump right into our next presentation, Advanced Hemodynamic Monitoring, both non-invasive and minimally invasive devices. Tammy Lee Sparacino, CCP LP. No disclosures.
I am going to be talking about a lot of products, and I'm not affiliated with them in any way.
Very good.
All right. So we're going to continue on this same topic of advanced hemodynamic monitoring that Katie just spoke on. I'm going to highlight a few other things. We have very little overlap here. I think it's going to be a good talk. All right. So let's get started. So let's just talk about a little bit of introduction. So we all know about hemodynamic monitoring, but what does it actually mean? Just the bare basics. It means that you're going to monitor cardiac output and organ perfusion. And keep in mind, hemodynamic instabilities, underlying causes can really be broken down to 3 broad topics: circulating blood volume changes, cardiac function changes, and vascular tone changes. Okay, what's the purpose? Why do we want to do this? Well, we want to monitor stability among patients. And we really, when we're talking about patients, we need to break them down into the non-critically ill versus the critically ill, because you're going to have different types of monitoring that you're going to do, of course. For a non-critically ill patient, just the standard monitoring of heart rate, mean arterial pressure, temperature, CVP, urine production, etc. Those types of things are usually standard enough, can give you enough information to see how your patient's doing. Now, when we start talking about the critically ill patients, the ones in the ICU, you're going to need probably a little more. You're going to still have your standard monitoring, of course, to give you the whole picture, but advanced monitoring is really the standard of care. It's going to give you cardiac output, preload, afterload, volume status, and most importantly, it's going to help you with trending parameters that can hopefully help you and your doctors taking care of this patient to really get a projection of where this patient is headed, so that you're able to intervene before they have any kind of harm. Okay? Thought this quote from Michael Pinsky from Critical Care 2005 was wonderful about talking about hemodynamic monitoring and its importance. What he has to say is, hemodynamic monitoring is a central component of intensive care. Patterns of hemodynamic variables often suggest cardiogenic, hypovolemic, obstructive, or distributive etiologies to cardiovascular insufficiency. Thus, it's defining the specific treatments required. Monitoring increases in invasiveness as required as the risk for cardiovascular instability-induced morbidity increases because of the need to define more accurately the diagnosis and monitor the response to the therapy. So what he's saying is that if we can predict the situation specifically for this patient by looking at all the kind of information that we have, especially with some of the advanced monitoring techniques, then we can do what we want to do, which is prevent organ injury. Okay, so what's the application? The application is simple. We just want to guide the medical management of these patients. And with that information, then we can do some therapeutic measures. We can do fluid resuscitation or de-resuscitation. You know, do they need volume or do they have too much volume? Do we need to put them on pressors instead? Do we need inotropes, etc.?
Is that really a word, de-resuscitation?
It certainly is.
Never heard. Have you ever? Has anyone in the audience ever heard that word? Nobody.
Yeah,
Nobody
it's a word
raised their
now.
hand.
It's a word.
You have two hands, so I count that as two people. Okay.
Let's talk about, in order to understand, really understand what these devices, how they're helping you know how to medically manage these patients, thought it'd be really important to do a little review on shock disease processes. So shock can be broken down into 4 different types. The one we're most familiar with is cardiogenic shock, because it basically has to do with the heart. You know, any sudden change in the heart's ability to pump enough blood to meet the body's needs. It can be caused by acute MI, valvular disease, cardiomyopathy, prolonged CPB times, post-cardiotomy syndrome, myocarditis, inotrogenic situations, pericardial disease.
Del Nido.
Yeah. No comment. But actually, the most common shock that is seen in these critically ill patients is hypovolemic. And that really has to do with, if you think about it, just the blood and the fluid compartments. You know, what's happening with the volume of the blood. Is decreasing in the circulating blood volume is what's going to give you that kind of shock. Can be caused from trauma, uncontrolled bleeding, whether that's anticoagulation or something innate in their coagulopathy, burns, electrolyte imbalance, most commonly with sodium, and also acute MI. Then one that might be not thought about very much, but it's actually a very interesting category, I think, is obstructive. So that has to do with the circulatory system as a whole. So it'd be any obstruction in the great vessels or the heart. So some common things that could cause that particular situation: vena cava compression, tension pneumothorax, pericardial tamponade, or high peak ventilation. And then we have distributive. Usually we're just thinking of it in septic terms, but it is actually all about the vasculature and any pathological hypovolemia. So it's just a loss of regulation in the vascular tone or permeability. You know, are you leaking? 3 categories of that are septic, which, as we know, is a dysregulated response to infection, lactate greater than 2, and persistent hypovolemia. Also anaphylactic, which is, of course, a massive histamine response. And then neurogenic, when you have an imbalance between the sympathetic and parasympathetic regulation of cardiac action and vascular smooth muscle. Okay, this is actually something that I've heard a lot about, but I didn't actually know how it was done in the most basic terms, so I thought this would be interesting to talk about. So fluid responsiveness, we hear about fluid challenges, but I really didn't know exactly how that was outlined, so I thought this was kind of neat. So a fluid responsiveness is just a fluid challenge. There's many ways to do it. These happen to be 2 of the least invasive and most common ones that are done at the bedside. So fluid responsive, positive fluid response would be a greater than or equal to 15% increase in the cardiac output in response to a fluid challenge, which is typically about 500 mLs. An intravenous bolus of fluid is given, and then you evaluate the response, just like Katie talked about. So a normal patient should produce a stroke volume increase, but shock patients will have a decreased rate of response up to 50%. So there's always a real danger of having fluid overload in these patients that are already have too much volume.
Yeah, if they're at the top of their Starling
Yeah,
curve, and then
exactly.
you lift, and then you add more volume, you drop them off the other side.
Exactly. So it's really important, if that's the type of challenge you're going to do, that you determine if the patient is in preload dependent portion of the Starling curve, just as Joe said. Okay, and then there's also something called passive leg raising, which I've seen this, but I had no idea that this is what was going on. So it's just like what it says, you do a 45-degree elevation of the legs while keeping the head at 0 degrees for 3 minutes. And you're just allowing the blood to, drain from the lower half, and you're getting the volume shift there.
You really had not done that?
I have never done that.
Do you know how many times I've done that?
I've never done it.
Oh my God.
Yeah, anyway. Yeah, it's great.
It's an ER tool, yeah.
So, of course, that's similarly done, but it's reversible. And it's only about, on an average, about 300 mLs. Normal patients will have a 10% equal to or greater than and cardiac output within the first 60 to 90 seconds. Now, shock or patients that have abdominal hypertension will have a decreased response. Of course, there's some dangers along with that, which increased intracranial pressures and risk of aspiration. Okay, I thought this was a wonderful graphic. So this breaks down shock. It's real easy to understand in the 4 types of shock, and then the things that you're going to see, what's happening, what part of the body is actually affected by that, and it just kind of sums it up really nicely. And just keeping in mind, when you break down shock to its most basic level, it's just an imbalance between the oxygen supply and oxygen demand.
That's a good slide.
Yeah, it's nice. Okay, so Katie talked a lot about this, but I thought this was also a really good graphic. It's just talking about invasive, it's comparing the most common ways to get some hemodynamic monitoring done, advanced hemodynamic monitoring. So it's invasive and non-invasive technologies. So you've got the most invasive, of course, being the pulmonary artery catheter, which again is the gold standard, but we've already been over, the kind of, if you have one, great, but you're not necessarily going to put one in every patient. There's too many risks. Then you've got your minimally invasive ones, which most of them rely on pulse pressure analysis, which we'll talk about a little bit more in a minute. You've also got your Doppler, which can be esophageal or transthoracic. You've got your bioimpedance or bioreactance, I guess it is, and then your applied Fick principle. Now, for the ICU setting in the operating room, you're mostly going to see the pulse pressure analysis or the Doppler. The other two, although there's a lot of promise with the bioimpedance, I didn't find a lot of ICUs that were doing that. And the applied Fick principle is also great, but too intensive for getting your calculations, so a lot of times they are just relying on these other things in those particular environments. Okay, here's another nice graphic where this is just kind of talking about where these particular types of technologies are used. So you can see all the way to the right, the ICU, for the most part, those patients are more critical, and so they're going to have the most invasive. They're going to have a pulmonary catheter. They're often going to have the pulse pressure analysis devices that are calibrated, but they also have some overlap in the uncalibrated ones. Then over in the OR, Doppler, I didn't see a lot where people were doing applied Fick, but this particular graphic says they are. And then the endotracheal bioimpedance says that's also another good place for it. And then over in the ER and on the floor, they're doing more of the non-invasive pressure analysis and possibly Doppler. All right. Okay, so let's talk about the one that seems to be the most common, especially in cardiac. And we're talking about technologies that use pulse pressure analysis or relying on the arterial waveform to get their derived parameters. So we've got the non-calibrated, or some of them are also auto-calibrated. There's one that is called ClearSight, and this is from Edwards. And the technology, or actually the device, is an inflatable finger cuff. And from that finger cuff, it gets arterial pressure waveform, and that's how it derives all of its parameters. Believe it or not, there's another one, and it's the next spin. And this is a company out of the Netherlands, and it is also an inflatable finger cup. Now, they do have their own different, complex formulas on how it's determining this stuff, but the basic idea is the same. They're both using arterial pressure waveforms, and they're completely non-invasive, just like a blood pressure cuff. Don't need anything else to go with those. Then you have your Lidco rapid system, and it's using power pulse analysis, and you're putting in your parameters of your patient, age, weight, and those kinds of things to help it fine-tune that a little bit. Then you have your flow track from Edwards, which is a pulse pressure analysis again, and it is mildly invasive because it can also be calibrated. Actually, that's not true. PulseoFlex is very similar to FlowTrack, but it can also be calibrated because what they really like you to do is obtain your cardiac output from another device and then input that so you have a more accurate baseline. So I thought that was kind of interesting. And then you have your I'm not sure how to say this one, ESCCO, and it uses something called pulse wave transit time. So it's, counting the time between the different waves in the pressure waveform. Then you have the little bit more sophisticated ones that are calibrated, and you've got Lidco Plus, and they use the lithium dilution. And that's similar to just thermal dilution, but instead of using saline, they're using lithium to measure how quickly that is getting dispersed. Then you've got your, I guess it's Pico Plus, and they use transpulmonary thermal dilution. And then this is the new one from Edwards because their old one,
Vigileo.
That's no more. This is the new one.
Really? The Vigileo's off?
Yeah, it's gone. So we've got the EV1000, and it's called the Volume View. So it's their most complex, and it actually looks like it's the device that is going to use the most information to try to derive its parameters. It uses the pulse contour analysis and the transpulmonary thermal dilution. And I believe that just launched within the last year or something like that. It's pretty new. Yeah.
I'll be interested to see more about that.
Yeah. Okay, so here's what I think. After we've talked all about this, kind of thought about these devices and, why we have them, what's interesting to us, especially as, ICU nurses and perfusionists, is can we rely on these when we have in-lane other devices that are, doing part of the circulation?
Vis-a-vis ECMO or VAD or something.
Or Impella or, balloon pump. And a lot of the, as I was saying earlier, a lot of the journal articles that I was reading did caution that you need to look at the big picture when you're looking at these numbers, when you have these other devices in. But I didn't find a lot of studies that this was their purpose. This is what they wanted to find out. But I did find this one, and I thought it was pretty interesting, even though it was a very small sample size. This was done in Sydney in 2013. They took all of their VV ECMO patients over 12 months that they were able to, match up, and it was only 8, but they did this study using the Edwards flow track because that's what they typically had in their ICU available. And what they were looking at is the usefulness of the cardiac output monitoring in assessing alteration in oxygenation status. So can those numbers tell us what's happening if we see a dip in, saturations? Can we look at that number and know we need to go up on flow? Are we going to have a response to that? So they compared resultant oxygenation saturations in response to varying the ECMO flow as a percentage of cardiac output. Now, when they looked at the individual patient data, it really wasn't conclusive. It was kind of all over the map. But then when they combined them together and they pooled them, they did see, although it wasn't a direct predictor, it went along with the same trending suggestions that the clinician thought that she should do or he should do anyway. So they determined that they thought this was useful and it was a success. When the ECMO flow was increased as a percentage of the cardiac index, cardiac output, the saturation, arterial saturations did increase.
With this device.
With this device, right. And the device was, they determined, found to be useful and assisted the clinician in determining when ECMO flows were needed to go up and when they were just troubleshooting, minor episodes of arterial desaturation. Yeah.
So essentially, was it essentially a validation study that there was a cause and effect, that we did this and this should happen when we do this, and in fact that is what we saw.
Exactly.
So
but only as a trend, not statistically significant. Again, they only had 8 patients.
True.
But they did find that with all of them, once they were pulled together, that if they did see a desaturation and they increased as a percentage of the cardiac output that the flow track was saying, that they did have the appropriate response.
Okay.
Yeah.
So, okay.
Kind of interesting there.
I think so.
Yeah, and I really wish I could find more studies on this, because I think this is a really interesting topic that, the more ECMO is increasing, the more these devices are becoming standard of care in ICUs. This could really be preemptive to helping perfusionists in particular, and nurse ECMO specialists, when we start having those more and more, on trying to look at the patient and see one more piece of information before making determinations. Do we need more volume? Do we need this? Do we need more flow? Those kinds of things.
Well, I think those are you want to let me let you finish with your conclusions.
Let me just finish this. So obviously more studies need to be conducted, and we need them to be specifically targeted at these devices, whether it be VADS, ECMO, or even the balloon pump, so that we can really look at these, especially because there's so many devices on the market, and although they all use the same basic idea, they all have different formulas. So I think we're going to find that some are definitely more effective than others, and it's going to depend on the particular situation. Maybe some are more effective when it is, a hypovolemic type of situation, and maybe some are more effective when it's, something else. At worst, these devices provide valuable information and can help predict trends that may be invaluable to preemptive medical management of the critically ill patients. But again, just as you said, I think it's really important that you're not relying on this, non-invasive, for the most part, device to determine exactly what you're doing. It's just one piece of the puzzle to help you get a better idea of what's actually going on in the patient.
It's very good, and I do think very good, by the way. Very excellent. Both of them were excellent talks today.
Here's all my citations, because I know you can read those. They're super tiny.
Yep.
And thank you.
Yeah, thank you very much. So I do think that's why I scheduled this, is because I do think this is a topic that, again, it's one of those. It's not sexy. It's not, it's kind of hard. But I think it's a really important topic that we have somewhat accepted,
right,
I guess would be the term. Accepted, really, to some degree, at least my experience has been mediocrity in actual monitoring. So I have several questions, if you don't mind. Have you used any of these devices, the pulse contour analysis devices in the ICU in your clinical practice as a nurse?
I have. I used the flow track when I worked in the trauma ICU. We used it routinely on our trauma patients, and we did not use PA catheters very often at all. And then whenever I've been working with CV patients, most of them had the PA catheters. And I guess the theory in the trauma patients was most of the time it's hypovolemic issues, because they're typically bleeding out, or they're septic. It's not very often that trauma patients, though it could happen for cardiac contusions and things like that, they could have cardiac issues, but more often than not, they're a younger population. They, you know, I'm trying to be sensitive and say that if they had heart issues, they typically would not survive their trauma, those sorts of things. So we used FlowTrack often because we were really looking for that stroke volume variation. And we would,
yes, I wanted to talk about that
we
too.
We would check for fluid responsiveness in them to kind of dictate our treatment.
Yeah, I mean, okay, so that brings up my next thing, and this is to everybody on the panel. In regards to these devices, when you used it in the trauma ICU, or when you used it in the ICU, have you ever used these devices at all?
I haven't.
You have no experience with them either? Okay, so I mean, I've got some experience with them as well, but even with just normal monitoring that we do, but specifically about this, then I'll ask Katie, did you have confidence in it? Did you trust it?
I did, as much as I trusted the waveform I was receiving. So you do the square wave test just like you would with a regular arterial catheter, and if the waveform was good and I could kind of sort of validate that with my non-invasive pressure, then yes, I would trust it.
Because how many times have we seen this, and this is to both of you, that the blood pressure looks horrible and everybody's running in there, something's wrong, and they're getting ready to resuscitate the patient. And they're sitting up eating Jell-O. Because
you always look at the patient
just
first.
fine. Yes, exactly. How many times
You have to look at the patient.
How many times does that not happen? And you know, everything looks good on the monitor, but the patient looks horrible. Does that happen with? Have you ever had that actually happen?
Where the
Trust but verify. A good one from the audience.
Which part, one way or the other?
Either way, where the numbers,
good or the bad.
The numbers were in no way reflective of what the patient actually was.
Oh, absolutely. Whenever a patient is turning septic, they go into a hyperdynamic state where their cardiac output and index is increased, and they're,
their numbers all look good,
but their labs look bad and they just don't look right. And so that's kind of your early stage before they go into full-blown shock. And so yes, you'll see that, and then you'll also see it's kind of more inexperienced clinicians who will go in and freak out over the monitor, but the patient's doing just fine. So you do see both. What's really challenging is when you have somebody who's more inexperienced and they aren't recognizing when the patient is turning for the worst, but the numbers look good.
On paper, they look like
on paper they look great, but they're actually really sick, and so someone who is less experienced may not catch on to that.
Yes, understand. Did you want to get a microphone? Yeah. There you go. That's even better, because everybody out in web world can hear your question as well.
Yes, with the ClearSight inflatable cuff, how does it actually work? You were saying that it worked kind of like a blood pressure cuff, but does it have to just inflate and deflate and stay deflated until you want another reading, or how does it actually work?
It works at on intervals. So the actual monitor that's running it is. It could still be run off their new monitor, the EV1000, I think it is. It's just this would be one module of it, and it's set at, I can't remember the interval, but it is continuous. So it will do not continuous. It will do continuous points for trending. So it's inflating, and then whatever the interval is, 6 minutes, 2 minutes, whatever it is, deflating, and so you're getting these points to be able to predict the cardiac output. It can't, just one reading's not going to give you, what you're looking for. It really needs points, data points for the arterial waveform.
And not necessarily an absolute cardiac output, but is the cardiac output increasing or decreasing or staying the same?
Right.
That's what it's going to tell you, I assume.
Yes.
Okay, so the LIDCO, I have a lot of experience with LIDCO too. And of course, I I was really an early adopter of it, and I really liked the device because you give the patient an injection of lithium, so at least you knew that you were doing something good for them. They would feel better afterwards if they recovered, if they survived, and you would, at the same time that you injected, you had the radial catheter connected to a pump that was pumping at a specific rate blood out of the radial catheter. So you gave it into the central line, and I think you could give it peripherally too. I don't think it mattered, but give it in a central line, let's just say, and then the amount of time it took before it came through the catheter past the sensor that read the lithium sensor, and said, okay, it took this long to go from injection to here, just pretty much like a thermal dilution, old style cardiac output, and then that is how it would calibrate. But now some people, and they used TEE. Of course, TEE is great for measuring cardiac output. Of course, you can. That's truly the gold standard.
Right.
The PA catheter is the gold standard, I think, only because the PA catheter was the only thing that actually existed for so long. So it's kind of the default gold standard, but it's not a very good gold standard. You know what I mean? So I think,
Yeah.
right, we accept its inaccuracy, so therefore we trust its accuracy. That makes no sense, but that's, I guess, what we really do. But I liked the Lidco more than I did the Vigileo. But Vigileo was made by Edwards, and Edwards was a very powerful company, and Lidco was made by a small company in England, and they really couldn't compete from a marketing perspective, so Vigileo basically just
Took over.
Well, didn't take over, but never let them really gain the traction I think that they deserved. I think they were I think it was a better device. But again, balloon pump in, irregular rhythm, atrial fib, any of those issues, poor waveform, you couldn't trust it. But I wanted to follow up on what I think is again another topic we should discuss, and that is stroke volume and pulse pressure variation. So stroke volume variation and pulse pressure variation, and what those actually mean in terms of cardiac function, volume status, and all of these things. So do you have any, did you look at those when you did it? Did you look at stroke volume variation and pulse pressure variation to assess the patient, or just stroke volume variation?
Just stroke volume variation.
And that, because I think that's another interesting component to all of this. But it brings up patients on balloon pumps. And I'm going somewhere with all of these questions. There's going to be a point at the end of all of this. How many here have used the fiber optic balloon pump?
I have.
Have you used it?
I don't think so.
It is.
I don't like it.
Does anybody? You want to talk about
Somebody does, because they keep buying them.
I know, but it's horrible.
So you know what it does? It uses a fiber optic inside of the balloon, so you don't have to have a pressure transducer. So it's deriving all of that.
Pressure. It's deriving your pressure waveform from this fiber optic device. And so it does, because the old balloon pumps had a central lumen that you could run a transducer from, or draw pressures, or draw blood, or whatever it is you wanted to do from it.
I think this one still has a lumen, but it's
teeny. Yeah. It's like, it's just enough to get the wire through, and that's it for insertion. But it's horrible. And when it doesn't work on the balloon console, it's a mess. But again, the balloon pump is being timed in automatic mode from the data being received from this fiber optic.
Which is very finicky.
And yet the balloon pump, which can do harm, it's not a benign device. We kind of consider it now just to be an aspirin because it's used so much and it's been around for so long. But it can do some real damage.
Well, and it's especially concerning when you are in, surgery with a cardiac patient, and you put this in, and you don't have a regular EKG, so that's your backup trigger, and now your fiber optic's not working, so now you don't have a trigger.
Right.
And it's real hard to fix.
It's real frustrating, very frustrating. Have any of you used NIRS, the near infrared spectroscopy, or like the what do you call that thing that they put on the forehead?
biz.
Not the biz, the other thing.
Oh,
the
cerebral oximetry.
Cerebral oximetry,
Sorry,
yeah,
that's what I
NIRS.
meant. Yeah.
Cerebral oximetry, where I've seen them put it in on the legs and stuff. Either of you have that experience?
I've used cerebral oximetry where I came from. We used it on every heart case and tracked it, and but never seen it used anywhere else.
Do you have confidence in the device?
Yeah, well, if your baselines are good, when we first got it, we had a lot of problems with the baselines. The pads not getting put on before anesthesia, which then you don't have a real baseline, right?
Right.
But yes, actually I do. We got a little bit of a on-the-job training with those as far as how it's related to being on cardiopulmonary bypass. And I have seen that, if you are out of range and your cerebral oximetry is climbing up there, it's a flow problem, it's a sedation problem. And as soon as you give those things, it drops right back down. So.
Or a transfusion if necessary.
Or a transfusion is necessary.
Whatever the case may be.
Right.
So none of you have experience with seeing it in any other part of the body,
No.
whether it be the down in the in the lumbar area. Have you seen it? Have you used it at all? Because I've seen that too. So where am I going with all of these questions? I'm asking all of these questions about all these different things to sort of illustrate a point. And I brought it up earlier. Let me see a show of hands of whom at the panel or anyone in the audience who thinks that we do a good job of hemodynamic monitoring of critically ill patients today.
Is this a trick question?
No, it's a real serious question. I'm being really quite serious. Okay, let me rephrase the question. Does anyone here think that given the amount of technology that we have and where we are, 21st century, does anyone here at the panel believe that we do that we do not do an adequate job of really good, trustworthy, accurate, believable, dependable hemodynamic monitoring of our critically ill patients? I'll raise my hand to that one.
Well, I think that your point is correct with all this technology, but we still don't know, just to my point that I made, we still don't know how accurate these devices that we are putting on there are, one, and two.
On any given patient.
On any given patient, right.
In the lab, they're all perfect.
Well, that's what I would say.
On
the ideal
patient,
the patient who is not moving, the patient who has a normal cardiac rhythm, the patient,
who doesn't have atherosclerotic peripheral vascular disease, which is none of our patients who doesn't have. Well, there's so many confounding factors.
Yeah.
Right. I just think that we have a lot of hemodynamic monitoring choices.
Sure.
But there aren't any of them that we can say this is our holy grail. This device works every time on every patient, or works almost always on nearly every patient, or anywhere even close to it. I guess my experience in medicine has been, in the critical care arena, has been that, I've seen more problems associated with monitoring than necessarily nice, easy on patients who are sick. Not your aspirin overdose who's in the ICU that's otherwise, healthy. I'm talking about really sick people that we've never really figured out how to best provide comprehensive hemodynamic monitoring without being overly invasive, like TEE or something like that, but that is dependable. NIRS, you do the cerebral oximetry, there's that famous article out, patient or pumpkin, you put it on a pumpkin with a light in it, in the pumpkin like a candle, and it'll give you a reading. If you put it on a patient who's alive, it gives you a reading, and the range is this.
Well, but don't
if you put it on a dead patient, it still gives you a reading, and it can be normal. And if you remove the patient's brain and put it on that patient, you wait till they're dead before you remove the brain, but remove the brain, it still gives you a reading that can be normal. So if it can do that,
Well, what's normal?
Can you believe
I mean,
it?
you're supposed to be using it as a trending device, not as a
absolute figure,
Right.
absolute number.
Yeah, you know, if your baseline was, I don't know, 50 on your left and 57 on your right, you know, you're watching that you are at least that or, you know, below and not above. But every patient, I mean, there was no hard number. Some patients had really low numbers and some patients started out really high, but that's just where they started. You just use that as your starting point. So are you saying that they had variation?
The pumpkin had variation?
Yeah, the pumpkin had variations.
The pump or
The pumpkin.
Pumpkin.
The pumpkin.
Yeah, the pumpkin or the.
Oh no, the pumpkin doesn't have variations, but it will give you a figure.
Yeah.
I mean, it will give you a range. I mean, each individual
It gave you the
pumpkin
normal for the
would
pumpkin.
give you, but yes, it'll give you a range. Some were normal, some were were abnormal, but no, the pumpkin didn't vary, so there wasn't variability.
Okay.
I guess unless the candle, you know, was getting like lower and weaker or something. I'm assuming then it did. But the title of the talk really had nothing to do with the pumpkin. It more had to do with the concept,
No,
patient or
right,
pumpkin. It was
right,
just a
right.
cute twist on it.
Yeah.
But nevertheless, the point is that I still feel, at least it's my belief, that given our technological advancements, I don't feel advanced hemodynamic monitoring has caught up to where we are technologically. I think we still do things like, why do we still have this as a problem? Why are we still struggling to know if we can trust this blood pressure? Why are we still seeing just things like that? How do we still not know that we're delivering enough oxygen to the patient just by being able to look at a number on a monitor and know that that's right? Like, we want to measure continuous DO2. There are devices that will do it. Lidco is one of them. I think this EV1000 or
Yeah, it
100 or
does.
whatever, that'll do it as well. But it infers a lot of information. But why is that so hard? Because it can be wrong. Can you really believe it? Can you really trust it? And why not? Given what we can do today, phones, little teeny phones, all the stuff we do, and we're still measuring blood pressures like we did back in the days before Alexander Graham Bell invented the phone.
Well, I think specifically speaking for the
Maybe not quite that far back, but close.
for the non-invasive or minimally invasive, because they're using you know an inline arterial catheter or something, they're deriving all of the parameters. Anytime you base a result on all derived parameters, you're going to have variability because it's not a real number. It's your best guess with the formula that you think gets you the answer right the most times. You know?
Yeah, that sounds, I agree, that is the case. I'm just trying my point though is I don't think that's really a good idea. I don't think that's great. I think we should know. I think we should be able to know.
What my point is I don't think you can have the kind of confidence that you want to have if you're basing all of your answers on a derived. You have to have something that is known for sure that leads to the next thing, like a math problem. You can only have so many variables, right? And sure, you can derive a few things, but if your end answer was from a derived that was from a derived that was from a derived, it can't be that accurate. And that's why it has to be, you know,
inferred.
It has to be used as a trending device.
Triple
only.
inferred.
Trending device only, which was the caution in a lot of the articles that I read, that you need to remember, look at your patient, look at everything else.
Eyeball test is the best test of all.
Right, and in the whole picture too. You know, even just looking at the basic parameter monitoring. You know, pressure, urine, color of the patient. You know, all of those sorts of things are real important. How you're going to determine this, you know, great advanced monitoring system that you're using.
So I got to tell you this. I got to tell you this story.
Oh gosh.
So we want to see their reaction to this. This is a true story. So I was visiting somebody, and they were doing like out of the country mission type thing, and it was in a Spanish speaking area. and we had done a heart procedure, and we were sitting back in some room or whatever, and just chatting about stuff, the case, and everything went fine. And nurse came in and told them to say, we're really having trouble. They were doing anesthesia actually. They were having trouble with the blood pressure. It wasn't working right or whatever. And he said, "That's okay. I'll be there in a few minutes. That's fine. Don't worry about it." And a little while later, they came back and said, "No, they were really having trouble with it. They can't get a good blood pressure, and they're just having a really hard time with measuring the blood pressure." And they even did a cuff because they had an indwelling line. They did a cuff, and it's not reading either. They're really having a problem getting the blood pressure. And so he said, that doesn't sound good. So he said, let me get back there. So I went back there too, and got back there. The patient had coded. The patient was full code. I mean, had been code, and that's like 15 minutes later. But the blood pressure, they were having a problem getting a blood pressure because
on a dead patient.
There was no blood pressure.
Right.
Oh, God. I was like, okay. I think I'll make my way to the airport now before the authorities get involved in this and get out of this country. So anyway, any final thoughts about all of this?
I would just say that the biggest thing is you have to look at your patient first. You can't just rely on one number and go off of that. You have to look at the total picture. You have to see what's tracking and trending with everything. And I think one of the things I would like to mention is that if you have somebody who the doctors aren't looking at the numbers that you're deriving from whatever method you're using, you really should question, should we still have this PA catheter in? Should we still use this flow track? Should we still, do we still need to look at this? If nobody's gonna look at the trends and treat accordingly, then you have to weigh whether your benefits outweigh your risks still.
Well, that's the infection risk issue.
For sure.
Is if you're no longer using the data, take the line out.
Correct.
But if you're going to keep the catheter in, use the
it.
doggone data.
Right.
That makes sense to me too.
And
exactly.
make sure that it's accurate as much as you can.
And therein lies, of course, the problem is make sure that it's accurate. And
but
that's
you're gonna look at all factors on your patient, and you're
Right.
going to look at all your numbers, and does the data match what you're seeing in your patient?
Right.
Does the data match what you're seeing in your lab values? Is the total picture coming together to give you an accurate assessment?
Yes. Can you use the microphone, please, because we can't hear you.
And is your training consistent in the ICU so everybody's getting the same information and using the technology the same way for each patient?
Correct.
And interpreting the information the same way?
Correct. Yep, it's a good point.
That's a very good point. In fact, that's an excellent point, that the training needs to be consistent. I agree with that 100%. So with that said, I think it's been an excellent session. I've really enjoyed it. It's been great. Both of you did great lectures, and I feel like I learned something today, which is important for me. I hope everybody out there learned something as well. Something I didn't talk about too much during the opening remarks, and maybe you guys can give me some guidance on this and some help with this as well, is, and we want to make sure that this goes into the library as well, David, so when you edit these videos later, keep this up if you could, is we're looking for people who want to present. We're looking for people who may be watching this that say, hey, I can do that. I've got a lot of information on that topic, or I have a passion for this particular topic, and I've really done a lot of work on it and have a lot of experience and studied it. Whether you're a perfusionist, whether you're a nurse, whether you're a respiratory therapist, whether you're a physician, nurse practitioner, PA, it doesn't really matter. And, at least my opinion is there's a multitude of benefits associated with doing these kinds of programs. One, you learn more. When you have to create the presentation, you learn more than anyone that's out in the audience for sure, number one. It's really good, I think, for professional development. I think that it makes you a more sought after and a more valuable person when you go and looking for a job, changing jobs, employer, or your current employer, whatever the case may be. You're bringing positive repute to your institution, but also to yourself and to your profession. And we're looking for people like that. So, you know, being that this is something that I love, I enjoy it, you know, I really, really enjoy doing this. And this is somewhat new for both of you. Would you maybe tell people what you think of it from a, you know, from a perhaps a something you sort of kind of jumped into? You made the decision and said, yeah, I'm going to do this. And what's the experience been like? And what would you tell people out there that may want to get in touch with us? And our contact number is going to go up our website. So please send us an email, call me, whatever you want to do. But Katie or Tammy, either one?
It's never a dull moment.
True.
We have fun.
We have fun. It is.
Well, I think too, this particular environment in the studio, it's a little more relaxed. It might appeal to people who don't necessarily like to get up in front of a big audience. They think they need to be an expert on something. I think it's an opportunity for personal development. You know, you can get a topic that maybe you know some about, maybe you have an interest in, maybe you don't. But you're going to research it, you're going to learn about it, and the more people we have who present different ways and teach different ways, the more people we're going to reach, the better our overall community is going to be.
I think you're absolutely right. That's a very good point. Ms. Kim, any final thoughts on that?
Come join us.
Come join us.
Come join us.
What do you think about it from a nursing perspective? I mean, you know, we didn't really talk that we're going to be transitioning from, you know, just PerfWeb, which is what this predominantly is. Then we're going to be adding the nurses, and of course there's going to be NurseWeb, so it's going to be webinars similar to this, but designed specifically for the ICU nurse. And of course my hope is that they will eventually, there'll be enough crossover that the two disciplines will work more closely together. Now we work close, but I think being educated more closely, because there's things that are very important to us and things that are very important to you, but really all of it should be important to all of us. And I think just having that knowledge is going to make you a better, stronger clinician and a better team player. But what do you think about it from the nursing perspective? You want to talk a little bit about what our goals are moving forward?
I think our goals moving forward are to deliver really dynamic presentations in a way that isn't being done before, to make it fun, to make it just really relaxed, and where everyone is learning together, and where we have a community of critical care nurses who are really involved and excited about learning.
Yeah, and I like that, learning and teaching and all of the things that are associated with it.
Well, and this round table that we always do, good thing I'm not writing anything, is really important, because it just, anytime you have discussion about any of this stuff, especially when you have those interesting cases that you like to present and talking about that, I think that's invaluable. I think sometimes, you know, you're going to work, you're coming home, you're doing a good job, but you may not be taking that extra time to sit down and really discuss what happened to you, how did you do that, oh, that makes me think of this, and maybe I could do that, and those sorts of things. And I think that is what makes us better practitioners.
Yeah, I agree. And sometimes, you know, unless you're married to an ICU nurse, or you're married to a perfusionist, or you're married to somebody that you both do the same basic job, even just married to someone who's non-medical, because that's also the case. You know, I think medical people, it's all we talk about. And then when you're married to someone who's not medical, well, there's, you know, no one really understands what this. So, and I think you're right. The lecture's great, but it's always the discussion that comes afterwards. And we want to get more people more involved. So it's very important. So please, our contact number is going to be put up, or our contact email address. Reach out to us, you know, send me an email, send Katie an email, do something, and get yourself involved. All I can tell you is you're going to be welcome here. Although I think that the traditional academic style is important for certain things and for certain people and certain topics. I think that there is, I think your point was very right on mark, is that there's a lot of people, and I'm included in that, that are more clinical, anecdotal, experience based, and not necessarily just data, multivariant analysis of this and that. Those are important things, and I'm not in any way discounting those. But most of my colleagues, most of my friends, I don't have that many that are really in the academic world. Most of the people that I associate with are kind of like me. You're in the trench, and you're just doing the work. And what do we see, and why do we do this, and what is out there that can help us be better in that environment? That's sort of my perspective on all of
I agree.
this.
And it's fun.
I think it's fun. I do. Of course, I love it. I enjoy it. I'm glad you like it. Do you like it too?
I do. It's
Good.
fun.
This was your first presentation.
Yes.
This was your first official presentation.
First official
well, I think you did a fantastic
Thank
job.
you.
I really do.
Thank you.
I really do. I think you did a great job. We were very happy with it.
Thank you.
Any other comments from the massive studio audience? None? Okay, terrific. Not that the studio audience is massive, it's just there's so many. It's a massive number of studio audience. Is it? I guess it's an audience eye. Audience eyes instead of an audience eye. Yeah, multiple. Like fish. Or
I think we're going to move right along.
Okay. See you tomorrow. Dr. Balan's going to be here. And I know you have to watch an ECMO tomorrow. You were scheduled to be, or today, and then also tomorrow. So you have to go to the hospital and work. And then you have to come back tomorrow, and you have to go back to the hospital tomorrow after coming here. So Dr. Balan's going to be here. If you can't make it, I know everybody out there will be disappointed because I really enjoy having you here. I really do.
you.
But I'm letting you know that if you can't make it, you can't make it. We understand that. And we'll see all of you tomorrow for the day 3. And Dr. Balan's going to be doing a TAVR-SAVR update. And he's also going to be talking about how and they do it very rapidly, some good strategies for rapidly cannulating patients having TAVR who already have all this access and without having to go through a whole bunch of hoops, but to get that patient on ECMO very rapidly, get them supported, get them supported in their get them on circulatory support very rapidly, and be able to complete the procedure, and then withdraw both the tools for putting the TAVR in and the circulatory support. But it's going to be interesting with the TAVR and SAVR update because TAVR is really gaining a lot of popularity. And he's a TAVR guy, and I have some misgivings about its overuse in the low risk population and whether it truly is the best choice. I'm not 100% sure, but we'll see. We'll talk to Dr. Balan tomorrow. I'll have that debate with him tomorrow. See you all in the morning.
All right.
Good night.
Thank you.
Let's start with the basics. What's the goal of autotransfusion? The goal of autotransfusion is to return the highest quantity and quality of red blood cells to patients with the least amount of waste as quickly as possible. Take a look at what goes on inside an autotransfusion device. There are 3 categorically different methods of blood processing: passive cell salvage, which uses a Latham bowl, continuous cell salvage, and dynamic cell salvage, which is available only in the Autolog IQ. Dynamic cell salvage uses algorithm-driven intelligent blood sensing to make micro-adjustments during processing in order to recover high-quality blood fast, automatically. How does it work? There are 3 things that distinguish dynamic cell salvage. First, there's the IntelliPath bowl. One bowl size works for most procedures. That may seem counterintuitive, but it's designed to work that way very effectively. Now here's where it gets really interesting. The Autolog IQ uses an adaptive 2-stage fill process to get high hematocrit with less waste. It's a little like filling a soda glass. Pour it in all at once, and you know what happens. With the adaptive 2-stage fill, the system does an initial fill. It pauses briefly to compact the red blood cells. Then it adjusts the second fill speed, slower for low hematocrit, faster for high. That way, you keep more red blood cells and lose less into the waste bag. The third key feature is the pulse wash. See these little indentations? They are part of the IntelliPath bowl design. They disrupt the red blood cell pack during the wash, which helps optimize saline penetration for an effective wash cycle. The pulse wash makes the wash process more efficient by adjusting the saline volume, depending on the characteristics of the red blood cell pack. Each pulse volume is designed to help minimize red blood cell spillage. All this happens automatically. With the push of a button, you're providing high hematocrit and quality packed red blood cells for the patient with just one program. You might think that this intelligently calibrated process would be slower. Not so. The Autolog IQ processing rate is approximately 3 minutes. Every now and then, you may have an exceptional case where you want to override the automated setting. No problem. Just press the setting you want for immediate override. The Autolog IQ system consistently delivers high-quality blood product automatically. Simply genius.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOT device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the epoch that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.